All right, great. Thank you, Joseph. I appreciate it. Good afternoon, everybody. I'm excited to be here. I love talking about drugs. So this really has become a passion of mine, which is helping the patients and helping people find the best medication that they can to treat the challenges that they're experiencing, in this case, mental health challenges. I work with an awesome team here at Provo Canyon. I do these kind of mini presentations, sometimes off and on with other staff, with therapy, and oftentimes I learn a lot more than I go to teach when I'm with the other disciplines in the profession as well. So grateful to have the chance to talk to you guys just a little bit. One disclaimer, I guess, I'm going to go over a lot of medications today, but I'm not going to cover all the medications out there. If I don't bring one up that you guys are interested in, make sure and throw the question in the chat, or just ask me at one of my pauses, and we'll kind of gear the discussion really to the direction that you guys lead it. I have the slides and we'll go through those. Try to hit some of the important topics, some things that are going on right now in the world of mental health regarding pharmacy and medications and that kind of thing. Little background about myself: been here at Provo Canyon for about 8 years and absolutely love it. I really do. And I did my bachelor's degree here in Utah, went up to Idaho State University in Idaho and did my PharmD up there, and then got some additional training and did my board certification here in psychiatric pharmacy. And then, like I said, great group. So I feel like I learned more every day that I'm working here. So hopefully we can have a good discussion and pass some of that on today. With that, I'm going to share my screen and pull up my presentation here.
Oh.
All right. Joseph, did that show up okay?
Yep, that looks great.
Okay, perfect. Okay, so this is what our discussion will be today. So medication used to treat depression and anxiety. We'll go into a lot of different detail. We're going to talk about side effects from these medications. We will touch on serotonin syndrome. Some of the medications we use to treat anxiety can also cause dependence, tolerance, addiction, that kind of thing. So we'll touch on that as well. We're also going to talk about a lot of the more minor side effects that people experience and what causes patients to sometimes discontinue medications early or get scared or feel uncertain about what's happening as far as side effects. We'll also talk about some of the ways to mitigate those side effects if it's a medication that the patient needs, that they should continue on. We will talk about strategies to choose the right medication, because that is just that's a challenging thing in the world of psych. There's not a blood test we can do like some of them in cardiology and others and say this is the medication we need. So we'll go over some strategies there. Just circling back real quick too to the medication side effects. One thing I really want to do and have tried to put together for this presentation, I know we have a lot of people on the call with a therapy background, and I'm hoping to bring out some of the side effects that you may be able to spot, either dangerous ones and get them into care quick, or some that you may be able to spot and explain what's going on just a little bit to them, or warning signs and that kind of thing. And then we will finish up talking about antidepressants used in bipolar disorder. And the reason for that is we have to kind of change gears when we're treating bipolar depression. We can't use all the same medications because sometimes those medications that work for depression end up causing more harm than good in bipolar patients. So. Okay, so depression medications used to treat major depressive disorder. Obviously, there's many levels and different types of major depressive disorder. Postpartum depression, that's an important one.
Scheduled for
bipolar depression.
Our regular time.
I think we've got somebody that needs to mute their microphone. And then, like I said, with bipolar depression, just a couple caveats there. Seasonal affective disorder, and then there's a lot of other types of depression that are out there in conditions that mimic depression that these medications are used to treat. Okay, so goals of pharmacotherapy are using the medications when we're treating depression. First thing we're trying to do is alleviate the feelings that the uncomfortable feelings that they're feeling. Sadness, hopelessness, self-doubt. It's important that the patients understand that It'd be really cool, and it'd be great if we could eliminate those feelings, but that's very unlikely to occur. What we're trying to do is alleviate those feelings. Interesting note with that, they've done exhaustive studies, well-controlled and good studies, and then reviews on psychotherapy and pharmacotherapy combined. And the jury's not out on this one. When you combine the two, results are better. And so just giving somebody a medication and having them walk away sometimes happens, unfortunately, but is not the best. If we can combine the medication with some therapy and help them understand and how to help them deal with the feelings that are still there, the self-doubt, whatever it may be, results always end up better. So we want to return the patients to a state of optimism and self-confidence. We want to improve their ability to function at a higher level. And this obviously is going to be patient specific, and it's going to depend a lot on their baseline as far as what type of function we're trying to get them to. Oftentimes we're trying to return them to baseline function, but in some cases, if they've dealt with depression for years and years, we're not just trying to return them to their baseline functioning, but hoping with the aid of therapy and medication to get them to a higher level of functioning, new ways of thinking, new ways of acting, and new ways of doing, really. We want to improve our patients' ability to achieve restful sleep. That's a big part of the medication therapy, because restful sleep in and of itself helps with these conditions a lot. And with depression and anxiety, disrupted sleep, I mean, they almost go hand in hand a majority of the time. And then things like reduce their tendency to isolate and withdraw from social situations, and obviously additional goals depending on the patient's challenges. Okay, so how do we choose a medication when we're trying to treat depression? So like I said, at some point it's going to be awesome. We're going to be able to do a blood test, a genetic test, something of that nature, and we're going to be able to say, Dan, these 3 meds don't work for you, these 2 will. We're not there yet. I will point out there are some genetic tests out there, and they are good, but they are far from comprehensive at this point. They give us bits and pieces of information, but they don't give us the whole picture. There are situations where the genetic test will even come back. I had one within the last couple months, a patient who had a genetic testing done, and they had done really well on a medication in the past, but that showed up on this genetic test as one to avoid. And we put them back on that medication because the reason the genetic test was saying they should avoid it is because their body metabolizes it or breaks it down a little bit slower than it should. Well, that's no big deal. We just lower the dose a little bit, and patient returned to doing well and was doing great. So we're getting there. We're moving in the right direction with the genetic test, but still far from comprehensive in my personal opinion. So we've got specific patient characteristics, their age. Is it a kid? Is it a geriatric patient? Their weight affects it, whether they're male or female biologically affects it in some cases. We're looking at the severity of the symptoms. There's some medications we use, particularly in an inpatient setting like this, that are, they're a little more heavy duty. They have a little bit more, they have more side effects, but they're necessary in patients that are acutely suicidal or are really suffering and have not responded to other medications. Where on the flip side, if we have somebody that comes in, they're experiencing some moderate depression, they've never been on a medication, they haven't tried therapy, there are going to be a lot of lighter weight medications, so to speak, that we can use first on that type of patient. And we'll get into all of those. Location of treatment, which I just touched on, which is, are they in a hospital, an inpatient psychiatric facility, or are they at an outpatient clinic? In an inpatient setting like this, for severely ill patients, we can make changes in medications and get them on and off medications in a matter of days. And in that same situation, it would take weeks to months in the outpatient setting, because we're able to watch them close. We're able to move up on doses quick, come down off of other medication more quickly, because they're constantly monitored, both medically and also being seen by our therapists and our nurses as well, so we can see if something's coming out as a result of the quick changes. Side effects. This is a big one, depending on the patient, and we'll talk about this a little bit later on with specific drugs. All medications have side effects. Every medication does. There are situations where patients take a medication and don't feel anything. And that's great. I found in my career that tends to be a minority of the cases. Most of the time there is some side effect one way or another. And it's important that we help patients understand, hey, these are the potential side effects, may or may not happen, but they're not always a reason to discontinue the drug. Oftentimes, if they understand, hey, this could happen, they'll continue taking the medication when they need to, or continue taking it at least until they can see a provider and get an adjustment made. That being said, there are some side effects that are just, this is it, time to stop the medication, go see a doc today. And we'll talk about that. So it's always, yeah.
Lisa has a really good question. She's asking, doesn't it take antidepressants weeks before they start working?
Yeah, it does. And so I'm going to hold off just 1 minute on that question, because as I hit these different medications, I'll go over that. But you're exactly right. Many of the antidepressants take weeks to start working. Some we can see effects quickly, or at least some effects. And we can also go up on the dose quite a bit quicker here. And so we can see what it's going to do a little bit quicker. So it's actually one of the reasons we use some of the heavy hitters, so to speak, some of the medications that are a little bit more, I don't know the best way to say it, but heavy hitters, because they'll work a little bit more quickly and get a patient stabilized, with the thought that when they're out seeing their outpatient doctor, as they're a little bit better, they can potentially taper off some of those medications and stay on the ones that take a little bit, that are starting to kick in, that take a little bit longer to work. So, okay, so yeah, cost benefit analysis always with drugs. Each one has a different cost and they have different benefits. So, okay, so the question, Joseph, who did you say the question was from?
That was from Lisa.
Okay, Lisa, yeah. So Lisa, spot on, especially with these medications right here. The SSRIs, which are the gold standard, what we use all the time for depression. They're the selective serotonin reuptake inhibitors. So we've got Prozac, which is fluoxetine, Zoloft, which is sertraline, paroxetine, and Paxil, and so on there. So these medications take, generally speaking, for depression, about 2 to 4 weeks to really get working. Peak effects are 4 to 6 weeks out. So in a situation in a hospital like this, if we can take somebody and get them up on a dose quicker, there's a couple things that we can see. Number one, you can see what side effects they may be experiencing from it. We can go up a little bit quicker because we're monitoring them. We start to see some of the effect. A lot of patients, when they start these medications, do feel some sort of an effect. Sometimes it's positive. Sometimes these medications at the first week or two even make patients feel a little more antsy if they're dealing with anxiety. And then it tends to settle. And about that 2 to 4 week, or even 4 to 6 week, is when we start to see the best results from them. So here in our hospital, we get a patient started on one of these, and instead of taking 2 weeks to get them up to their therapeutic dose, we can get them up to we're talking about severely ill patients here, get them up to their therapeutic dose in, say, 3 days, combine that with therapy, helping them understand what they need to do to get themselves better as well, that we can get them in a good spot, 7 to 10 days here, make sure the medication is not causing any significant problems, that they can go out into the community and use what they've learned while that medicine continues to kick in. So overall, they're well tolerated. And it takes 4 to 6 weeks for peak effect. I will say for anxiety, it's more of a 4 to 6 weeks. For depression, we tend to see a little bit more after 2, so 2 to 4 weeks there. Notable side effects, so adverse effects. There's an FDA black box warning for the suicidality. This is primarily in adolescents and some evidence in young adults, where a patient who, we've had patients who were suicidal or just depressed, and then when taking the medication became more suicidal, or it just brought that out when it wasn't there before. So this does not happen often. It's extremely rare. Lots of theories as to why. We don't really know why. One of the prevailing theories is that we have a patient who's so depressed and just can't hardly function, can't do a whole lot. And when they first start taking these SSRIs, they do tend to be activating. They tend to perk them up. And there's some thought that maybe that gives them the energy and the ability to think through it, plan it, and to carry out or attempt suicide. We really don't know exactly what it is. There are some patients that just react really poorly to these as well, and it increases suicide. I will point out, though, it is rare, but it is important. It's an FDA black box warning. QT prolongation, which that's more of a heart thing we measure here. So if we have somebody with pre-existing certain types of heart conditions, not all heart conditions, but certain types, we watch that. Sexual dysfunction. So this is a big one. There's the studies confirm that SSRIs do, in many cases, cause sexual dysfunction, but the studies vary. Some of them say as low as 1 to 2% of patients. Some of them say as high as 80% of patients. So the general consensus is about half the patients get some sort of sexual dysfunction. It is reversible, like I noted there. Really important thing for patients to understand too. If this occurs, which it can be decreased libido, it can be difficulty achieving orgasm, it can be erectile dysfunction. There's a number of different things. There aren't any actual well-documented cases or studies of these effects persisting once the medication has been stopped. And so we're not worried about long-term irreversible problems here with that. Oftentimes, once the patient's a little more stable, simply a dose reduction can resolve whatever problems they're having as far as the sexual dysfunction. And in my outpatient job prior to this, I saw a number of cases where patients stopped these cold turkey because they experienced some level of sexual dysfunction and it frightened them. So if they can understand on the front end it's possible, then they'll continue hopefully taking it at least until they can be seen. Now, if we've got an outpatient who, got some mild to moderate depression, they're being started on a low dose of, say, Zoloft or sertraline, and they stop at cold turkey, life probably goes on just fine, right? If we have an acutely suicidal patient that we stabilize on sertraline, which is Zoloft, and then they go home a month later, they stop at cold turkey, the results could be absolutely catastrophic. So we want to just make sure they're aware of that. Serotonin syndrome, very rare, but it is life-threatening. And let me just jump ahead. Okay, we'll go into serotonin syndrome in just a little bit. So I'm going to pause right there before I just go into how they work. Any questions that you guys have or any in the chat right now, Joseph?
Looks like up until now, chat is pretty clear. Oh, we did have a question from Alicia. Which ones have higher risk of sexual side effects? Oh,
great question. So let's jump back to this slide. So when we look at these, most of them are about the same, but the one, Joseph, does that actually show up with my mouse there?
Yeah, I can see it.
So Paxil tends to cause the most. Prozac and Zoloft, and I guess technically in a CE I shouldn't be using brand names, but that's how they're recognized. So sertraline and fluoxetine tend to cause the least, and then the rest of these are kind of in the middle. But I will say they're mostly equal except for paroxetine. It stands out as causing the most. So it's actually used for males who have a difficult time controlling themselves. So sexual aggression and that kind of thing. Sometimes paroxetine is actually prescribed, particularly in those situations, to help tamp down libido and that kind of thing. So that's the one that kind of sticks out. It is seen more in women than it is with men. And there is an additional strategy, since the question was asked, I think I'll mention it. There's an additional strategy, which is, so we've got the dose reduction, but the other you can talk to a provider about is adding Wellbutrin. So if you've got a good effect or a partial effect from one of these, Wellbutrin, which is bupropion, if you add that on, that'll oftentimes reverse the sexual side effects experienced by SSRIs. Now, we don't want to treat the side effect of a drug with a drug that has more side effects, but if you need an extra boost for the antidepressant and it's an appropriate choice, then it can oftentimes solve that problem itself.
Again, a couple of people have asked if there are any long-term side effects with using these drugs.
Yeah, great question. I was surprised as I got into the field of pharmacy, how few long-term, like high quality long-term studies we have. We don't have a whole lot of them. Most of them are post-marketing. They're called phase 4 studies, where the FDA is relying on us in hospitals and doctor's office reporting strange or bad side effects that we see. But there isn't any evidence at this point that using these long-term causes any harm that we're aware of. No evidence of like kidney dysfunction or liver dysfunction. It does change the way we our brain is functioning, and we'll talk about right here on this slide. So I particularly like to be careful. I mean, there are times we definitely need to use them in children. We want to be careful because we are altering the way the brain functions a little bit, and so we want to be able to watch, for instance, children or a developmentally delayed adult carefully to make sure that we're not seeing any abnormal or untoward effects that are coming out in their personality and that kind of thing. So this is just, we'll go quick here. I could nerd out on this kind of stuff all day long, but I won't do too much here. So this is how the drug works. So this top part here is what's called the presynaptic nerve. So it's the first part. And this is like coming from our brain up here and connecting to a different part down here, the postsynaptic nerve in our brain. And this top one here releases a whole bunch of different chemicals depending on what's going on. So one of them is serotonin. And so as serotonin gets released, it's in this middle part called the synapse, and it allows that second neuron right here to use it. It binds to receptors right there, and it's using it. So when we have, although there is a study that has cast a little bit of doubt on this, long term, it's one study. What we understand right now is that serotonin does modulate and affect feelings of happiness. We know it affects feelings of anxiety as well. So when serotonin's in this synapse, it's exerting its action right here on this neuron. So we've got these right here, these little enzyme or these little channels, and they suck that serotonin right back up. So it can only be in there a little bit. So SSRIs don't activate or work on this these receptors on this nerve itself. What they do is they block this guy, which sucks all the serotonin back up in, so that serotonin can hang out here in the synapse or the gap longer and keep exerting its effort right here on this this neuron that is trying to signal. So that's kind of the general way of how these work. We do have some medicines that work directly on these. They haven't, some of them have turned out good, some have turned out really bad. We do have some that block the breakdown of serotonin right here. They're called MAOIs, and they're used in some patients, but they're a nightmare. They interact with about everything. You can eat too much cheese, aged cheese on those and die. So we try not to use those very often. Do see them occasionally though. Okay, so next ones here, these are the serotonin and norepinephrine reuptake inhibitors. So they have that serotonin component, but they also add in the norepinephrine component, which also has an effect on mood. And norepinephrine is also referred to as adrenaline, but the parts of the brain that this is working on, they don't give you the adrenaline rush that some other medications or certain life experiences will. And it's kind of interesting because these are second line, SSRIs are first line. And you would think that since we've now got serotonin and we've got norepinephrine, that these would be more efficacious. They'd be superior to SSRIs. They are another option, but they aren't superior to SSRIs. We'll try them after we failed SSRIs. Sometimes they work, sometimes they don't. But we usually start with SSRIs. But they are another option. So we've got the duloxetine, venlafaxine, which is Effexor, the Cymbalta, which is duloxetine, and then a couple others there. Usually the ones we see are that duloxetine, which is Cymbalta, and Effexor, which is venlafaxine. The others are still quite expensive. Prostiq, which is desvenlafaxine. You guys might have seen some of that being used. It is generic now, but it's basically just the active form of venlafaxine. So we have so much more experience with venlafaxine, which is Effexor, that we tend to stick with that. So you'll notice here the characteristics are very similar, and the adverse effects are very similar to SSRIs. The one key difference here is you do have to kind of keep an eye on blood pressure with these ones, the SNRIs. If we have somebody who already has hypertension, high blood pressure, it's not controlled well, we probably won't start them on this. If you have high blood pressure, but it's controlled well, no problem starting on one of these. You just keep an eye on it. So they're an additional option. Some evidence that sexual dysfunction may be less with these, but that's kind of iffy. It's back and forth. Same FDA black box warning for suicidality. Okay, so I'm going to jump back real quick because I left something off. So right here, as far as why and how we're choosing a medication, when it comes to these SSRIs and SNRIs, There's a lot of different strategies. We went over some of those, but the number one predictor of success with one of these SSRIs or SNRIs is family history. Obviously, if we can get, immediate family that history, that's better, but even extended family plays a part in this. So far from 100% success rate, but it's still very good. So I've consulted on a number of patient cases where they're trying to decide which antidepressant to start. And that's the way I always go. Do you know anybody in your family that's been on one, and what were the results? If we had someone that started it and had a terrible result with, say, sertraline, which is Zoloft, we avoid that, move to another. Or if we've had, the opposite, which I've seen many times. And that helps to not start with the wrong one and jump through them. And this I think is a really important point I want to make. I've dealt with so many patients who are either here at the hospital or outpatient. I consult outpatient as well, who are struggling, they're suffering. And when I talk to them or consult with their provider, the patient's saying, well, I've already tried an antidepressant, didn't work, so they don't work for me. But with these SSRIs and SNRIs, it is not uncommon for it to take 2 or 3 tries before you find the one that works. And it speaks to how complicated and complex our brain is and how little we know, really. Because as far as we know, these all do the same thing. But for some reason, for me, maybe one of them is just the golden ticket and does wonderful, where for Joseph, the other one works well, So it's important that patients understand too that whether it was side effects or lack of efficacy, it is not uncommon to go to 2 or 3 before we find the one that does the trick.
Yeah, we have a couple of questions in the chat. So
Yeah.
Josh is asking, when someone wants to get off meds, what would withdrawals look like for an SSRI or an SNRI? Great
question. So let me just briefly hit on serotonin syndrome, then I'm going to jump to that slide. I think it is in just a couple slides. So if we'll hold off on that one because I'm going to hit it in a couple slides. But did you have a couple others there too, Joseph?
Yeah, Luann is asking, what about weight gain with SSRIs? Is that reversible?
Great question. Yes, it's reversible, but weight loss in any situation is challenging. So as far as weight gain with these here, paroxetine again tends to be the one that causes by far and away the most weight gain. This is the one that caused SSRIs to get a lot of the label they have for causing weight gain. Fluoxetine, which is Prozac, for instance, there's some controversy about that one, but we in the medical, about whether or not it causes weight gain, but we in the medical community will not give it to geriatric patients very often because it tends to cause weight loss or be weight neutral. Now, that being said, there are patients who individually have experienced different results. There's a variety of reasons that could happen on an antidepressant or getting depression or anxiety relieved. But generally speaking, we don't see that in the studies in fluoxetine. An internet search will produce far different results than what I'm saying here. But and then sertraline tends to be in that same category. But I know people individually who have experienced significant weight gain. So it does occur, but generally speaking, in the studies with those two, we just don't see a significant amount or any, in some cases, weight gain. The other three over here, citalopram, escitalopram, and fluvoxamine, also don't tend to cause it a lot, but can. It's a complicated thing because is it the drug causing it? We know some drugs cause it. In this case, we don't know that the drug itself causes it, but if we're treating, say, anxiety, we've got a patient who's really amped up, they can't sit still, they haven't been sleeping well. They start on a medication, maybe they start on therapy too. With therapy, they calm down. All of a sudden, they're sleeping more. They're sitting down, they're looking out the window, they're pondering, they're resting a little bit more. The number of calories they burn just in and of itself because of the change in their life plummets, which is good. That's where we need to get. And so, that's one of the reasons that you could see something like that as well. As far as it being, Sorry, I'm just clarifying in the chat here. You said it was Prozac that you don't necessarily get to elderly patients, correct? Yeah, so Prozac, which is fluoxetine, because we do tend to see that causes weight loss in a lot of patients. And oftentimes geriatric patients or the elderly patients, oftentimes they're having a difficult time eating anyway. So geriatric patients tend to have a lot of muscle wasting, lose their appetite. And so that's why, not in all cases, but in a lot of cases, we tend to avoid that. So. Great. And you might be
at some point addressing this, but one other question came in. Cameron is asking, as psilocybin is increasing in awareness and popularity, can you speak to potential risks of mixing these with SSRIs? He says, I'm assuming side effects, including serotonin syndrome, increase with dosage of SSRIs.
Yeah, so great question. I'm not going to speak too much to the psilocybin case because honestly, I haven't done a lot of research on it. I know the basics behind it. I do know there's some promising research, but I don't know a lot about the research. Like I haven't really dug in. So it is up and coming. I think there will probably be a place, my personal opinion, a place for it in the future in the medical establishment. But I don't know where that'll be yet. As far as mixing it with these, serotonin syndrome could definitely be a potential risk. Serotonin syndrome risk does increase with SSRI dose to address that portion, but getting serotonin syndrome on an SSRI alone is very rare. It's not common, but it is possible, so we want to watch out for. These are the signs, the symptoms here. Basically, we're looking for a situation where somebody becomes agitated, even totally confused, muscle stiffness, and then like their heart rate's up and their blood pressure's up and that kind of thing. So in fact, I mean, we had a patient today who outpatient was started on Effexor, which is the venlafaxine and SNRI in conjunction with an SSRI, which we don't usually do. And I was talking to her this morning and she said, well, why don't you guys usually do that? What's the problem? I said, well, it can elicit, and I listed some of these: agitation, difficulty sleeping, which could potentially be the starts of serotonin syndrome, definitely not full-blown serotonin syndrome. But her eyes got big and she said, well, that's why I'm here. That's what's going on. And it likely drug induced in that case. I don't know for sure, but we'll find out in the next few days when we discontinue those. Once again, that is not full-blown serotonin syndrome, but it could be the starts. It appears to be symptoms of excess serotonin in that synapse and in different parts of the brain. So if serotonin syndrome occurs, you get to the hospital as quick as you can, you get a patient there as quick as they can to be evaluated. There is no antidote. We use supportive care. You stop the offending agent. Body temperature can go way up, so cooling blankets. And then we've got listed here benzodiazepines and then cyproheptadine, which blocks serotonin. Whether or not they really help, we don't know, but we're gonna throw it at it anyway just to try to help it. So serotonin syndrome is a tough situation if it occurs. I've been practicing in psych for 8 years, a number of years before that. I've never seen a case of serotonin syndrome on a rotation. A lot of years ago, we were seeing a pediatric patient who had been to the ER. A 16-year-old was on a whole pile of psych meds, and the pediatrician thought that maybe their visit to the ER the weekend before was a result of that, but that's the closest I've ever come to seeing it. I don't want to downplay it. It's a serious issue that we need to keep an eye on, but it's pretty rare. So. Okay, so a couple other antidepressants here. Wellbutrin, which is bupropion, we mentioned. Sometimes this gets lumped in with SSRIs. It is not an SSRI. It does help quite a bit with depression. It can, and I use the word may here, it may worsen anxiety. We usually avoid it in patients with anxiety. That's a complicated statement because some of the professional expert guidelines will list Wellbutrin or bupropion as an option for anxiety, as like a third, fourth, or fifth line treatment. There are patients that do respond well for anxiety, but generally speaking, and I've seen cases here, of people getting admitted, and that's what happened. They got put on bupropion with anxiety, dose went up a little bit more, then got put on a benzodiazepine like Xanax or alprazolam, just to end up here stuck on that medication. And so it's great medicine though for depression. It doesn't cause weight gain. In fact, it's in one of the new weight gain combos the FDA has approved. I apologize. It's in one of the new weight loss combos the FDA has approved. If anything, it causes weight loss. Does not cause sexual side effects. In fact, sometimes, like I mentioned, we'll even reverse them. So, and it can be used particularly in females who have low libido, and other sexual dysfunction and problems. Whether or not it's really effective for that, we don't know, but it is used occasionally. One other thing with it, if you've got a seizure disorder, it's also not a great choice. Okay, this one's kind of loaded here, this antipsychotics. So antipsychotics, I don't know if you guys have heard of some of them, like aripiprazole, which is Abilify, olanzapine, which is Zyprexa, and a number of them, risperidone, which is Risperdal. So these are used to treat psychosis, and they can also be used as an add-on or adjunct to treat depression, mostly in cases of treatment-resistant depression. People have gone back and forth, the expert groups over the years on this. Actually, on what is today, the 14th, so just a couple of weeks ago, I believe it was the 3rd of this month, in the New England Journal of Medicine, or the Lancet, I think it was the New England Journal of Medicine, a study was just published on using Abilify, which is aripiprazole, to add to an antidepressant versus switching to a variety of different antidepressants or adding Wellbutrin instead. And hands down, best results we're seeing with adding the antipsychotic, which is aripiprazole or Abilify, the best results as far as quality of life and how their depression and mood was. Now, these have some side effects. So aripiprazole that I just mentioned, it's actually pretty clean. It does not usually cause weight gain. So we use a lot of that when we can, but it doesn't work for everybody. It's what's called a partial agonist as opposed to a full agonist, and that refers to partial stimulation of the receptor. One of the ones that has been proven to be very effective but problematic is Zyprexa, which is olanzapine. So olanzapine works well. You can increase the dose and escalate the dose well or quickly with very few acute or current side effects, but it can cause a pretty significant weight gain. So, I mean, 30 pounds in 6 months is totally possible on a medication like olanzapine. So you have to be very, very careful with that. We try to avoid it in adolescents. We try to avoid it as an adjunct for depression unless they have psychosis with it. And then at that point, we'll use whatever will work to treat their psychosis and then try to mitigate the side effects, but we have to be able to treat the psychosis. So, and then these mood stabilizers here too, which are like lamotrigine and Depakote, which is divalproex.
So Tina has a question. She's asking, does bupropion help with smoking cessation?
Oh yeah, so it does. Bupropion's got indications for smoking cessation, for I'm trying to remember all of them, but for weight loss, for depression. It's used off-label, even though it can cause anxiety. For anxiety in some patients, it's kind of like the multi-purpose drug. It's got a lot of different effects. So it's been proven to be effective to a certain degree in smoking cessation. Yeah, we don't do a lot of that here, so we don't use it a bunch just because patients are here for a short period of time. So we have to focus on the reason they're here for their psychiatric condition, and then make recommendations on smoking cessation and that kind of thing. But yeah, it has proven to be effective. Any other questions as we move on here? Okay, so these medications, the TCA is going to hit them real quick. We don't see a lot of them anymore. They're just as effective as the SSRIs. They just cause a lot of side effects. So sedation, and then this right here, anticholinergic side effects. Let's remember that by can't see, can't pee, can't spit, can't poop. But it can cause constipation, urinary retention, blurred vision, dizziness, a lot of problems there. So especially in the elderly. One other important point here on this medication, if patients overdose on the TCAs, so you might have seen like amitriptyline or doxepin prescribed, those are the most common, it can kill them. This messes with your heart rhythm pretty significantly. It's tough to reverse. If a patient overdoses on a bottle of SSRIs, say like sertraline or fluoxetine, which are Zoloft and Prozac respectively, it's very dangerous and they need care immediately in the hospital, but it is so much less dangerous and life-threatening than are these medications. So we try to avoid these, especially in anybody who has attempted or considered suicide by overdose. Usually we actually just use these for their side effects now, which is interesting. So nortriptyline and imipramine, they're used for kiddos that wet the bed all the time, just a small dose before bed because it causes urinary retention. And then amitriptyline is so darn sedative we'll use that in low dose. We don't use much here, but in the medical community for sleep, for somebody who doesn't have any depression, just a low dose at night. So. And then,
Sorry, Jenny would like to know if you could discuss briefly SSRIs and how they interact with alcohol use or weed.
Yeah. So there isn't a direct, like, as far as what the drug's doing in the brain, it doesn't directly interact with alcohol. It does, it's causing some psychiatric changes, as does alcohol. And some of those SSRIs, like paroxetine, can be sedative. And some of them, it just depends on the person. Some people can take these medications and experience a lot of sedation. So if you add that to alcohol, you've got an additive, not a synergistic, but additive effect there of sedation. And otherwise, there's no real direct interactions, but you do risk, if someone's taking an SSRI, it's because they're dealing with some pretty significant depression or anxiety of something of that nature. So if we add a CNS drug, central nervous system drug like alcohol to that, we're asking in many ways for a problem, because we're causing ups and downs. We're trying to stabilize something with the SSRI, and then we're taking all these other receptors and we're activating them big time with alcohol. Then the alcohol's gone, then activating them again. So over here with the SSRI, what it's trying to do is going to be altered, because you've got all sorts of different things going on with the rest of the brain that's being caused by the alcohol. So best not to mix them. As far as weed, exact same thing I just said. No direct interaction with the way the SSRI is functioning in the body. It doesn't make it build up. It doesn't make you get rid of it quicker, any of that. But once again, we're altering the rest of the brain chemistry while we're trying to stabilize a situation. And so it's going to be challenging to ever get a full stabilizing effect if we're up and down and all around with other drugs or medications that are affecting the brain. So you have to use extreme caution in those situations, because it's tough to treat the psychiatric disorder if we've got other factors affecting the brain.
A couple of other questions really quick. Hannah's asking if we'll be discussing medication with pregnancy. And then Brianna's asking if you're aware of trazodone affecting short-term memory.
Yeah. So as far as pregnancy, I didn't include that on this. Joseph, in the future, I'd be happy maybe on one of ours or the beginning of next one, we could do that. I will tell you there are safe, effective options with SSRIs in pregnancy. They've been tested a lot. And but you do want to consult with your OB on that, and I can go over in a later presentation like which ones generally considered the safest in breastfeeding and in pregnancy and that kind of thing. There are differing opinions among expert groups as well, but the same couple that are usually in that category. So and then trazodone and short-term memory. Trazodone can affect short-term memory. Yeah, not like a permanent effect, like it damages the brain, but trazodone is sedative. It does tend to slow things down a little bit in the CNS. And so especially if you just started taking trazodone, you could have some memory effects. Most people don't. And that kind of CNS depression tends to go away with trazodone after you use it for a little while. But if I were taking trazodone and I was experiencing, short-term memory issues, I'd get back into my doc. I'd pick something different because there's a lot of other sleep options. I do have actually not a patient, a friend. It lives in my neighborhood who was experiencing significant memory issues. And that was the primary contributor, but most people don't, so. Anything else there, Joseph?
I think that's it for now.
Okay.
I'm just going to drop in the evaluation link for anyone who needs that if you're getting ready to leave us. And I'll drop in the code that you'll need when you're filling out as well. Thanks.
All right. So last thing I'll hit on, and then, I love the questions. So thank you all for the participation. As a result, we won't get to the anxiety portion. So Joseph, we'll talk, and maybe I'll change my next one a little bit unless you've already got that sent out. So we'll stick to the depression. I do want to hit real briefly treatment-resistant depression, because you've all probably seen the billboards for ketamine or heard of it. So treatment, they're varying definitions, but basically it means normal treatments aren't working for you. And oftentimes it's defined as having failed 2 or more antidepressants. There are a couple options. You can augment, or you can switch to a whole different class of antidepressant. you can augment, which is what we talked about with like one of the antipsychotics, aripiprazole, or these lamotrigine, lithium. There's a lot of different agents you can augment with. And then ketamine is another option. So far, ketamine data is very promising in my personal and professional opinion. It affects, what it does is it blocks the NMDA receptor. That's its main thing it does. We really don't know all that it does. Has to be used carefully and under the supervision of a qualified healthcare professional. So you get the dose, you sit there, you're observed for 2 hours for blood pressure issues, heart rate issues, and dissociation, where you're kind of, just outer body, and then you need someone to drive you home. But people have had some pretty amazing results when they have been constantly depressed for years. And I think it's a great option if you go talk to the provider that does it, and you're a candidate or a patient's a candidate. I have seen lives turn around that just responded to nothing before, almost people you could call permanently depressed. And so it doesn't work for everybody, but being used appropriately at the right doses under the care of a qualified healthcare professional, I'm pretty positive and hopeful about the future of ketamine. And I better hit this real quick. If you're going to discontinue an antidepressant, if you're going to stop it, this slide all summed up real quickly is make sure you got a doctor involved, and make sure you don't go cold turkey. You need to move slowly. Oh, in fact, I guess somebody did ask that question, so I better address that, Joseph. Side effects: if you stop cold turkey, rebound depression is one of them. And rebounds, not recurrence of the original symptoms, that can occur. Rebounds when you actually experience worse depression for a short period of time. Now, this is once again stopping cold turkey. And then withdrawal syndrome. So SSRI withdrawal syndrome usually involves things like a headache, nausea, feeling a little bit antsy, insomnia, and agitation. And so that's stopping at cold turkey. But if you what we usually do is start to wean a patient off and watch. And, we get down to say half the dose, visiting with them. If they're doing fine, we keep going. If we get to half the dose and they're like, hey, all those same feelings that I had before are coming back, it's not time yet. So we'll go back up to the normal dose. So as long as you do it carefully and slowly, it can be done safely. And they're not hard to get off. They're not addictive, so to speak. So I think with that, Joseph, probably better wrap it up given the time, and I'd be happy to figure out how to pull in anxiety next time. Any other last minute questions?
You may have addressed the one about ketamine already. It was just Jenny asking if it worked for anxiety as well. Can't remember if you touched on that.
Yeah. So there is off-label anecdotal evidence and some smaller studies that are showing it works for anxiety. I mean, if I had anxiety that I couldn't treat with anything else, I'd probably go try it. I'm confident enough, but that's just my personal opinion. Going by the data, there's not solid evidence that it'll treat treatment-resistant anxiety yet. I do think it is possible and even potentially likely that we will get evidence of that, but we just don't know for sure yet.
Chad asked about TMS treating resistant depression.
Yeah, so great results with TMSs outside my expertise. So I don't know a whole lot about it. I do know after, in discussion with some of the psychiatrists here, there's been some really good, they've personally had some good effects with it. I don't, but like I said, not my field of expertise, so I can't really speak to it exactly, but it seems what I'm hearing is good.
And then it looks like someone asked, what are the reasons / qualifications for a patient to taper off a medication?
So reasons or qualifications to taper off of a medication. So one would be intolerable side effects. So side effects occur, right? But if they're intolerable, the other one is there's a lot of patients that want to stop. They want to try to handle their condition without the medication, which is totally reasonable. If you look at studies, though, when we're treating depression or anxiety disorder, those who stop before about the 9 to 12 month mark have a far higher relapse rate than those that go at least the 9 to 12 months on the medication. So I recommend if someone is in a condition where they need to start the medication, unless there's like an intolerable or dangerous side effect, we don't consider stopping it till we're about a year out. And then you just kind of see, you could start to taper off and if you're like, I got this now, I've been going to therapy, I've got some good strategies of coping, I've got better ways of thinking, maybe in a position to be off it for a long time or forever. But some people, as they start to wean off, they hit half or quarter of the dose or even all the way off, and those same just dysphoric, nasty feelings or anxiety just comes back, and they say, no, I'm better on this medication, I need to be taking the medication.
Here's a great question by Alicia. She's asking, what have you been doing with ADHD patients with the lack of medications out there for use due to production issues?
Yeah, that's challenging. I get that question all the time. So we have a couple options. This sounds so odd to say, but the best option right now is to call pharmacy after pharmacy after pharmacy and just see who's got it in and who will fill for a new patient. I deal with this personally. My son, he's on an ADHD medication. I'm filling it in a different city. It's the only place we can find it. You do have the option to switch, but if you're on a stimulant like say Adderall, it's been back ordered and difficult to get for so long that so many people have switched to the other stimulants that they're almost harder to get right now than even the original Adderall, which is the amphetamine, dextroamphetamine mix, salt mix there. So honestly, calling around, checking in with your doctor, asking them if they've had luck at any specific pharmacy, but it's a problem. I mean, it's a real problem. You can switch to non-stimulants. So there's Strattera, which is atomoxetine, and then Intuniv, which is guanfacine. But, if you've already been stabilized, you're doing well on a stimulant, I'd be hard pressed to want to switch to a non-stimulant because it works in an entirely different way. So it's a challenge right now. A lot of people are suffering as a result of that.
Danielle is asking, would you recommend, let's see if I'm pronouncing this right, guanfacine as an alternative for ADHD medications for youth?
Yeah, I mean, it's a good medication. It works very differently than the stimulants. So I'll use my son as an example, and I think the experience can be extrapolated. He's tried a couple other ADHD medications, and we found that Adderall works. It works well for him, has fewer side effects. And so for him, I would rather go without, and he would rather go without than try to switch to guanfacine, which is in the extended release version, which was approved for ADHD as Intuniv. But if he struggled so much that he couldn't say his behavioral issues or just could not pay attention in school, I would go to my doctor and talk to him about switching to guanfacine with the full understanding that this is a very different medication, but let's see if it's something that will work in the meantime. And who knows, maybe you even try it and it works better. I mean, it's always possible, but you just need to understand it's not a cousin, it's not a sister, it's not related, it's a different medication.
So we had a question a little ways back here from Lisa. She was asking, is it bad to take antidepressants for years? Does it mess with the brain in a bad way?
Yeah, great question. So as far as we know, no, it isn't bad, and it doesn't cause any problems that we're aware of. Whether or not tolerance develops, which is where you get used to it, is really hard to say because depression, waxes and wanes anyway. It is not uncommon for a patient to go a few years on an SSRI and then feel like it isn't working anymore. We don't really have any physiological basis for that, evidence, but it does seem to happen in practice. So sometimes switching to another one is beneficial. Sometimes coming off of it for a little while is beneficial, but that's a very patient specific situation. If you take it and it helps, and you can go off it, fine. But if you take it and without it, you're suicidal or patient, I mean, we don't want to mess with that. So there's no evidence that we have right now that long-term use of SSRIs leads to any cognitive dysfunction or any altered thinking or any permanent or long-term issues with the brain.
Noel's asking, do you have any idea how long it takes for generics to come out? He says it was about the same amount of time, she's asking, is it about the same amount of time for most meds? He said, I have a child on Abilify and insurance doesn't cover it, and we're hoping the generic will come out sooner than later.
What medication was it?
It looks like it's Abilify, if I'm pronouncing it right, Quillicichew.
Let's do this. So if whoever asked that question, if you'll email Joseph, and Joseph, if you'll email me, I'll give you the exact date that's going to go generic. I can look it up, but it just varies on the med because they have a certain amount of time. I don't know if I'm still up to date on this. It used to be 20 years, but that included like all the studies and trials. So if a drug got approved quick, they may have 5 years of patent left. If they push it clear to the end, they may have less. And then there's these ongoing legal battles where they're like, hey, we should get it extended for our patent for brand name longer. So it just really depends on the med. But if you want to shoot an email to Joseph, I'd be happy to look that one up and let you know at least what it's planned on right now.
One more question. What is a better option than trazodone? BJ's asking.
For sleep?
For sleep, BJ? Yes.
Okay. So, so there are some that work a little bit better that don't cause the memory issues, but they also have risks of dependence and drug abuse and addiction. So one, Ambien, which is Zolpidem, it tends to have a quicker onset and last for a shorter period of time than does trazodone. So we tend to see less of those issues in the morning with memory or grogginess. You do have to be careful. It can be habit forming. Most people handle it just fine, but if it's somebody who has a history of drug abuse or family members or people around them, you try to avoid that. Melatonin, which has probably been tried if somebody's using a prescription drug, is a good option. And then it really depends on what else is going on and what other medications they're on. But the Ambien, and then there's one called temazepam. Once again, we run the risk of certain things, but they do tend to last for a shorter period of time in your body than does trazodone. So they're alternative options. But like I said, it really depends on a lot of factors. If we've got drug abuse with it, we love to use quetiapine, which is a low dose antipsychotic. We use it in a low dose, and it works really well for patients who are like, who have drug or alcohol abuse issues, helps to stabilize them and get them to sleep, but can cause side effects of weight gain, metabolic problems. So we don't use it generally. And anyway, there's a lot of different moving pieces there, but a provider should be able to help sort that out. If you explain to them, hey, trazodone, or for your patient, hey, trazodone just it's causing this and this and this, they should be able to move to another class that's shorter acting.
Great. Any other questions before we let Dan go? This has been a great presentation. I have a lot of thank yous here in the chat and people saying that it was so informative. Thank you, Dan.
Oh, great. Well, thank you guys. I appreciate. Well, sorry we didn't get to anxiety, but I absolutely love the participation. I'd rather miss part of the presentation and talk about what you guys want to talk about than just read off my slides and go through it all. So thank you for the participation.
And those who are wondering, we will be convening again on the 28th of this month. Dan has offered to present again. So it sounds like we already have a few things that we want to address at the beginning of that presentation. So hopefully we see a lot of you. I'm going to drop the link to the evaluation one more time here in the chat. Go ahead. I've had a few people asking already, how do I get credit for this? Go ahead and fill out the evaluation. Use the code MEDS314. That's the code that you'll need to enter the evaluation. It'll verify that you were in attendance today. Also, I'm posting my email. If you run into any issues or any problems with that evaluation or accessing it, shoot me an email. If you have any other questions, maybe that you thought of later that you wanted to ask Dan or something, go ahead and shoot those to me. We'll see if we can get those answered, if we can do that. And then I'm also posting the link to our YouTube channel in the chat. Check back there in a couple of days. I'm hoping to get this class uploaded by that time and watch for those certificates. If I've sent out a certificate and you've maybe filled out the evaluation after I sent it out, shoot me an email about that as well. I'm able to go back and verify your attendance, and I'm able to send that certificate to you if I still owe you one. So reach out with any questions. And any other issues or questions that we had before we let Dan go today? If not, I will thank you for your attendance. And again, thank you, Dan, for all the work that you put into this presentation. It's thoroughly educational. I think you answered a ton of questions for us, and we are grateful for that. All right, thank you, everyone. We'll see you then on the 28th for our next one.